All right, welcome. Today, we're diving into something pretty amazing, pharmacology. But we're not just going to list facts. We're going to follow the story of a single drug, trace its incredible journey through the human body. And look, if you're an aspiring clinician, this isn't just good-to-know stuff. Understanding this journey is literally the bedrock of safe and effective medicine.
So think about it. What really happens after you swallow a pill? I mean, it seems so simple, right? You've got a headache, you pop a pill, and boom, a little while later, the pain's gone. But what happens in between? Well, that tiny pill is actually the hero of an epic journey, a whole drama of biology and chemistry. So let's follow along and see what's really going on.
Okay, first things first, let's meet our main character. What is a drug, anyway? According to the WHO, it's basically any substance with a mission. And that mission is to modify something in the body, a system, a disease state, all for the patient's benefit. So whether it's fighting off an infection, taming high blood pressure, or just getting rid of a headache, this is our hero. Its whole job is to step in and restore balance.
You know, like any good hero, a drug has a few different names, kind of like a secret identity. First, you've got the super long, complicated chemical name that only chemists really care about. Then there's the flashy brand name, the one you see in ads, like Crocin. But the one that really matters for us, the one you have to know as a clinician, is the generic name, paracetamol. This is your universal language. It cuts through the marketing noise and ensures everyone's on the same page. Seriously, always use the generic name. It's all about clarity and patient safety.
All right, let's get into part one, the journey through the body. This is where we talk about something called pharmacokinetics. And really, it all boils down to one simple question. What does the body do to the drug?
Now, it is absolutely crucial to get these next two terms straight because they are the two sides of the same coin. You've got pharmacokinetics and pharmacodynamics. Think of it this way. Pharmacokinetics is the journey. It's everything the body does to the drug. Pharmacodynamics, on the other hand, is the action. It's what the drug does to the body when it finally reaches its destination. So just remember, journey, then action. Get that down and you've got the foundation of pharmacology.
So this journey of pharmacokinetics, we can break it down into four main stages. And lucky for us, there's a super handy acronym to remember it, ADME. That's A for absorption, actually getting the drug into the bloodstream, D for distribution, sending it out to where it needs to go, M for metabolism, where the body starts to break it down, and finally E for excretion, getting rid of what's left. Let's dig into each of these steps.
Okay, so our drug has been swallowed, and right away it hits a major hurdle. This is called the first pass effect. See, when you take a pill, it gets absorbed from your gut, and from there, the blood goes straight to the liver. And the liver acts like this super efficient security checkpoint. It immediately starts breaking down or metabolizing a chunk of the drug before it even gets a chance to circulate through the rest of the body. For some drugs, like nitroglycerin, this effect is so powerful that a pill would be totally useless. And that's exactly why you see it given under the tongue. It gets absorbed directly into the bloodstream and completely bypasses that first pass through the liver.
So what if you need to bypass that liver checkpoint completely? What if you need the full dose right now? Well, that's where intravenous or IV administration comes in. By putting the drug directly into a vein, you get 100% bioavailability instantly. Nothing is lost. In an emergency situation, when you have zero time to waste, this is why an IV is the gold standard. It's the most direct, most reliable route.
All right, our drug made it into the bloodstream. Now what? Now it's time for distribution. It's got to travel to its target. Think of the bloodstream as a highway system. Some drug molecules just cruise along on their own, but others need a ride. They bind to proteins like albumin, which basically act as a taxi service, shuttling them around the body. But it's not always an easy ride. The drug might have to cross some serious barriers, like the famous blood-brain barrier, which is like Fort Knox for the brain. Only certain types of drugs, usually ones that are lipid-soluble, can get a pass to enter.
Next up is metabolism, which is basically the body's drug processing plant, and the main factory is the liver. It's a two-step process. In phase 1, a team of enzymes, most famously the cytochrome P450 system, gets to work. Their job is to make the drug more polar, which is just a fancy way of saying easier to dissolve in water. Then, in phase 2, the body tags it with another molecule, making it fully water-soluble and ready for disposal. Now here's a super important clinical point. Lots of different drugs use the exact same CYP450 enzymes. It's like having one highway exit for 5 different towns. This competition is a huge cause of dangerous drug interactions, so you've got to be aware of it.
Now, sometimes we can actually use the body's metabolism in a really clever way.
We do this with something called a prodrug. Think of it like a Trojan horse or a secret agent. You give the drug in an inactive form. It's just sitting there, not doing anything. Then the body's own metabolism flips a switch and activates it. The perfect example is levodopa for Parkinson's. The brain needs more dopamine, but dopamine itself can't get past the blood-brain barrier. So we give levodopa, which can get in. Once it's safely inside the brain, the body converts it into dopamine, right where it's needed most. It's a brilliant strategy.
And finally, we've reached the end of the journey, excretion, getting the drug out of the body. Now, there are two main ways this happens. Most drugs follow first-order kinetics. Think of it like a percentage sale. The body clears, say, 50% of the remaining drug every hour. The more drug there is, the more it clears. Simple. But then you have zero-order kinetics. This is different. It's like a flat rate. The body removes a constant amount, say 10 milligrams every hour, no matter how much is in the system. And this is where it gets dangerous. Drugs like alcohol or high-dose aspirin follow this. Their disposal system can get overwhelmed or saturated, leading to a toxic buildup. As a future doctor, you absolutely have to know which drugs play by these riskier rules.
Okay, so our drug has survived the journey, it's been absorbed, distributed, metabolized, and it's on its way out. But before it leaves, it has a job to do. Welcome to Part 2, the main event. This is pharmacodynamics. The drug has reached its destination. The question now is, what does the drug do to the body? So how do drugs actually work? Well, most of them work by interacting with things called receptors on our cells. The best analogy is a lock and a key. A receptor is the lock. A drug that is an agonist is like the perfect key. It fits in the lock, it turns, and it opens the door. It triggers a response. Now, a drug that's an antagonist is like a key that fits in the lock, but it's the wrong key. It gets stuck, it won't turn, and more importantly, it blocks the right key from getting in. Adrenaline is a perfect agonist, it revs things up. Atropine is a classic antagonist, it blocks things.
All right, let's clear something up that trips up a lot of students. The difference between potency and efficacy. They are not the same thing. Potency is all about the amount of drug you need. A more potent drug gives you an effect with a smaller dose. Morphine is more potent than pethidine because you need fewer milligrams for the same level of pain relief. Efficacy, on the other hand, is about the maximum possible effect. It's the ceiling. Morphine has a much higher efficacy for pain than aspirin. You could take a whole bottle of aspirin and you'll never reach the pain relief of a single dose of morphine. And listen, as a clinician, 9 times out of 10, efficacy is what you really care about. What's the best possible outcome I can get for my patient?
So, with any drug, there's a big question. How safe is it? How much wiggle room do we have between a dose that works and a dose that's dangerous? Well, we have a number for that. It's called the Therapeutic Index, or TI. It's basically a ratio that compares the dose that's effective to the dose that's toxic. The bigger that ratio, the wider the drug's safety margin.
And this is where the rubber meets the road clinically. A drug with a high therapeutic index, like penicillin, is great. It means there's a huge gap between the effective dose and the toxic dose. It's a relatively safe drug. But a drug with a low TI? That's a different story. Things like digoxin or lithium have a very narrow window. The line between helping the patient and harming them is incredibly thin. With these drugs, you have to be vigilant, monitoring your patient very, very closely.
Okay, this brings us to our final section, safe use and clinical practice, because knowing all this theory is one thing, but applying it safely and responsibly in the real world, well, that's the whole point, isn't it? Let's be real, no drug is perfect. They all have potential side effects, which we call adverse drug reactions, or ADRs. We can split them into 2 main buckets. First, you have type A reactions. A is for augmented. These are predictable. They're basically just too much of a good thing, an exaggeration of the drug's intended effect. Think of getting low blood sugar from a bit too much insulin. Then you have type B reactions. B is for bizarre. These are the weird, unpredictable ones that aren't related to the dose, like a sudden, severe allergic reaction to penicillin. You just don't see them coming.
All right, sometimes things go wrong, and you're faced with an overdose or a poisoning. In those moments, you need to know the antidote, and you need to know it fast. This right here is life-saving, high-yield information. If you take nothing else away, learn this. For an opioid overdose, you give Naloxone. For paracetamol, it's N-acetylcysteine. For benzodiazepines, it's flumazenil. Seriously, burn this table into your brain. You will save a life with this knowledge one day.
And it's so important to remember that in medicine, one size never fits all. You can't just prescribe from a textbook. You have to look at the individual patient in front of you. An elderly patient, their kidneys and liver might not be working as well, so you'll probably need a lower dose. And what about genetics?
Someone with G6PD deficiency could have a massive breakdown of red blood cells from a drug that's safe for most people. Or so-called slow acetylators can build up toxic levels of a drug like isoniazid on a standard dose. You have to treat the person, not just the disease.
And just as a quick aside, it's good to remember that before a drug ever gets into your hands to prescribe, it has been through an incredibly long and rigorous testing process. It starts with Phase 1, which just asks, is it safe in a small group of people? Then Phase 2 asks, does it actually work? Phase 3 confirms that it works in a much larger population. And even after it's approved, Phase 4 is ongoing surveillance to catch any long-term issues.
So after all that, what's the big takeaway here? It's that pharmacology is so much more than just memorizing a list of drugs and dosages. It's about understanding the story. It's about knowing the entire journey a drug takes, from the moment a patient takes it to the moment it hits its target and all the way until it leaves the body. That understanding, that whole narrative, is what separates a good clinician from a great one. It is the absolute foundation of safe, effective prescribing.
And that brings us to one last, really exciting thought for the future. We're getting better and better at reading our own DNA. It's getting faster, it's getting cheaper. This new field is called pharmacogenomics. So it makes you wonder, right? Are we heading towards a future where every single prescription isn't just for you, but it's perfectly tailored to your unique genetic code? Imagine that. The journey of the drug is far from over.